Well, we're looking into the state of rural health care. That's today on Nevada Week.
Support for Nevada Week is provided by Senator William H. Hernstadt, Cashman Equipment, and additional supporting sponsors.
As the 2020 election season ramps up, healthcare remains a top focus and campaign talking point. Here in Nevada, access to rural healthcare continues to be a challenge for the 300,000 Nevadans that live on our state's rural land. Some rural communities have seen hospital closures, reductions in emergency services, and limited specialized mental health and dental care. The outcomes for rural families could be tragic. On this episode of Nevada Week, we're discussing the state and future of rural healthcare in Nevada, plus informing voters about key policies and platforms that can change the face of healthcare in our rural communities. Joining us for this conversation is Ali Shaheen, Chief Medical Officer for the Nevada Health Centers, and Tanina Capurro, Nevada State Dental Health Officer for the Nevada Department of Health and Human Services, Heidi Kaiser, writer, producer for Nevada Public Radio, and John Packham, Associate Dean for the Office of Statewide Initiatives at UNLV. Well, thank you so much for being here. We really appreciate it. I've been looking forward to this discussion. And I want to start by just getting kind of a baseline of where we are, what the state of rural healthcare is. And John, I just want to go to you first. Some of the national level data that we see, mortality rates are 23% higher in rural counties. There's higher preventable hospitalization rates as well. And it looks like that those gaps are sometimes widening. Are we seeing similar trends in Nevada?
We are. As a general rule, you could say that rural populations and communities are older, typically. They're poorer. And I would say that they're sicker. And to echo your comments, what we see is mortality rates, even when you adjust them for those populations being older, higher for COPD, higher for cancer, higher for diabetes, certainly. And so those disparities have persisted despite gains that we've made in improving access and coverage and trying to ensure the economic viability of those facilities.
Gotcha. Ali, Nevada Healthcare Centers, you have urban locations, you have rural locations both in Southern Nevada and throughout the entire state, actually. What are you seeing? You're kind of more boots on the ground here, but you're also looking kind of at the administrative side of things.
Right.
What's some of the good, what's some of the bad that you see in rural areas?
Sure. So as John was mentioning, people are sicker in rural communities, and the providers are working that have less resources. So there are less primary care physicians, less specialists, less other healthcare professionals, less hospitals, less emergency rooms, etc. So there is Nevada Health Centers. We have clinics in many rural areas. In many of these rural areas, a federally qualified health center, which Nevada Health Centers is the only place where people go to get their health care. So we're very happy to be able to provide that care in these rural communities. But at the same time, there is a lack of resources. There is a lack of specialist care. There is a lack of some other healthcare professionals, dentistry, mental health. One of the things which we are seeing now that with the advent of telehealth, we're able to fill some of these gaps, at least partially.
And you mentioned that federal qualified healthcare centers are taking the place sometimes of hospitals that have closed. Heidi, I want to go to you. You have covered extensively not only the closing of Tonopah Hospital in 2015, but what the aftermath has been, and then you've done a lot more coverage on just rural healthcare in general. From the patient's perspective here, what are some of the things that patients are really missing that you have reported on?
The things that we heard again and again, particularly in Tonopah, had to do with the lack of emergency care. We spoke with one gentleman who has taken emergency flights out of town 5 times for acute gastrointestinal episodes. We spoke with people who had to drive to the nearest hospital when they were in the process of having a crisis, some type of acute crisis. And we spoke with people who had lost loved ones because they weren't able to get to emergency services quickly enough, or they got to the nearest ones and then realized that that care still wasn't sufficient and they had to be taken even farther away. Yeah. So the kinds of stories that we were hearing primarily had to do with emergency services, but we also heard repeatedly about a need for obstetrics and then the specialties that both John and Ali have mentioned, cardiac, diabetes, the kinds of things that can lead to acute episodes where patients may not be getting enough ongoing day-to-day care, and then or they let it go because there isn't any specialist there for that, and they let it go until it becomes a crisis and leads to them needing that emergency care.
And we'll talk about the specialty care in a second. I want to come back to just the emergency room and the hospital aspect of this, John. We mentioned Tonopah, but there are other rural areas that have hospitals that are doing relatively well, I would assume. I mean, they're still in operation. Why is that? What's the difference between maybe a Tonopah and an area like Ely that has a
Well,
hospital?
I think there's a couple of things going on. Hospitals like that in Winnemucca and Ely and other places, what they do is a couple of things really well. They have really strong, vibrant outpatient clinics. So I would say that that's the tragedy of Tonopah, is that they lost that outpatient clinic. But they also have usually ERs in combination with community paramedics, which is a great strategy to not only address ER needs, but population health issues that paramedics are well equipped to do. And then a number of the hospitals also have long-term care facilities, so skilled nursing beds that have as many as 25, 30, even more beds that are usually full. And so what they are doing quite well is addressing community healthcare needs.
And Antonita, to that point, addressing what the specific needs are of a community, let's talk about maybe what we're doing well here. All these specialized care gaps that we've already discussed here, you specialize in something like dental care, but what are we doing well in our state when we're looking at more of the specialty care here?
Well, so what we're trying to do is we're trying to increase the outreach in our rural areas. So we know that 40% of Nevadans report that they have not had a dental exam in the last year, and 30% report that they're having oral pain in their mouth that's untreated. We see those numbers exacerbated in those rural areas. We know we have higher rates of decay in our school-age children in rural Nevada, and we see more and more closures of dental practices in those areas. And what's been very interesting for me to see when we go out to these areas to provide services is that illness is universal, but access to care is not. And despite...
And can I ask you specifically for something like dental care, what is the biggest barrier then? Is this again kind of a workforce thing, or is this more of the business end of why centers are closing?
Well, I think that it's kind of a combination. Without a large population, a provider may not be able to sustain a bricks and mortar type of clinic. So we have to think more innovatively about how to provide services to these patients. And it's not just having dental insurance. I mean, we have had expansion of Medicaid services. Children are covered for comprehensive dental care. But just that financial mechanism is not enough to ensure that there will be a provider there when they need that care. And dentistry is one of those things that is completely preventable. If you have routine care and preventive services, you can avoid an emergency situation. But for patients that are not able to access those services, it becomes a life-threatening emergency when now there's suddenly something that needs to be taken care of and they can't go down the street for services.
Right.
And Antonina made a very good point about finding innovative ways of treating some of these gaps. Yep. Some of the things I mentioned, telehealth. So for example, we have a clinic, a health center in Jackpot. It's a small community of around 1,200 residents at the border of Idaho. And we have a health center there, which is staffed by a nurse practitioner. Fantastic nurse practitioner, provides in-person care. But because of the size of the community, he sees around 3 to 5 patients a day. So it can become challenging to keep this model viable. Now, we made him a telehealth provider. So with that, he sees his in-person visits in Jackpot, but provides also via telehealth care to patients to some of our other areas across the state, including some of our urban areas, which have got a high patient demand and where we have, some challenges with access. So it's a win-win situation. So we're able to keep that clinic viable with an in-person provider, as well as him providing telehealth care to some of our other sites.
So John, it sounds like telehealth is one way of taking the limited number of healthcare professionals we have and then potentially just kind of expanding just because they can see more patients at a time. The workforce gaps, just in general, is another challenge that we have right here. I was looking at some of our rankings, and we're ranked about 45th for active primary care physicians. But you've mentioned that we've had 900 primary care physicians that we currently have that are new over the last 2 years. When we're looking at the data, I mean, what has the evolution been of our workforce pipeline, maybe over the last 5 years, to make sure that we've got all the right healthcare professionals that we need in our rural areas?
Well, I would say, for starters, it's improved. We have been a state that still continues to attract physicians and other healthcare providers. We've done a fabulous job of attracting nurse practitioners and PAs to this state. It would be difficult to imagine how bad our primary care capacity would be in Nevada had we not been successful in recruiting not just physicians, but nurse practitioners and PAs to the state. I think we've also done some innovative stuff, and to build on what Ali was saying with respect to telehealth applications, UNR has a program that's been up and running for 6 or 7 years called Project Echo Nevada. And what the starting point of ECHO is a recognition you can't have cardiologists in small rural communities. You can't have hepatologists and oncologists, but what you can do is improve the capacity of those primary care physicians, nurse practitioners, and PAs to learn from specialists based in urban areas like Reno. And so what we've done, instead of a provider-to-patient consultation, we've utilized those specialists to provide case consultation and expertise to those rural communities and providers so that they can treat and manage those patients in their community. Sometimes that they need to see a specialist in Reno or Las Vegas or Salt Lake City, but a lot of those chronic conditions can be kept in those communities. And it's not only good for the patients, it's good for those facilities because they are being treated and reimbursed and kept in their own communities.
Gotcha. And increasing capacity through telehealth, and obviously a direct link is increasing capacity just in how many medical school seats that we have and developing the workforce pipeline. We had the opportunity actually to talk to UNLV Medical School. Let's take a look at that.
Providing medical services in rural Nevada has always been complicated. One of the primary focuses of the new medical school at UNLV is to recruit students who graduate from Nevada colleges who will do their medical school training here and hopefully their residencies here and stay in Nevada.
Every year, the UNLV Medical School accepts 60 new students into its rigorous program. 90% are from Nevada, and that's on purpose. According to Dr. Files, students are more likely to practice where they feel at home.
Each year, the UNLV School of Medicine has a pre-med day where we invite candidates that are at college level to come and visit and discuss career in medicine. And we actively attract candidates from the rural areas from throughout Nevada.
Although this pre-med day inspires some interest, Dr. Files says it's important to light that spark much earlier.
There needs to be programs that begin as early as middle school in developing their interest and showing them a path forward. And only then can we really successfully fill our positions with those candidates.
Another important piece of this puzzle, residencies.
Well, residencies, I think, are the most important step in keeping doctors in Nevada. People who complete their residencies oftentimes stay in the community or the state that they train in. Nevada specifically is underrepresented for graduate medical education support from the federal government. We've been reaching out to our policymakers in Washington to ask for a redistribution and to create new spaces so that other new essential residencies can be started, residencies that are sorely needed throughout our community and throughout our state.
So we talked a lot about workforce development right there, and I want to switch the conversation just to the state and the regional policy here, if I could. And let's start with workforce development. I think we have a lot of state legislators that some of the seats are going to be open in the 2020 election. We have voters that are kind of looking for information. So kind of keep that context here of what information should voters know when we're talking about this. But Ali, let's start with you. middle school was mentioned there. Residencies is a major gap right here. What do you see really as being the major solutions here on really developing the right workforce pipeline for rural Nevada?
Right. I think it's multifactorial. Our healthcare education system is really urban-centric. So as we heard, moving some of these education out from urban areas to rural areas, I think will be key in helping medical schools, PA schools having rotations, having even the huge part of their studies done in rural areas. Residencies, again, part of or even the full time of their residencies being done in rural areas is I think very important. Our organization has been partnering with University of Nevada for the family medicine rural track. So every year 2 resident physicians go out to Elko and get their training there. I think we have to see much more of that.
Antonia, what do you think we need on the education side of this?
No, I completely agree with Ali that we need more exposure for our students of what it's like in rural Nevada. Recently, the Nevada Oral Health Program partnered with the Southern Nevada Health District for a Medical Miles for Rural Smiles project, where we had a collaborative partnership to provide immunizations and preventative dental services. And coming back to the university and to the Dental Association and discussing what we had seen, taking intraoral photos, and kind of really presenting this information to them, I think was very eye-opening. And a lot of the students are very interested to go out and explore Nevada and perhaps take over some of the practices that will be vacant soon. But without a mechanism to get them there, it's very difficult. A lot of students have no idea how geographically diverse Nevada is. So we really need to do a better job about exposing our students to this so they feel comfortable and they understand what life would be like if they took over a practice in those areas.
Interesting. One of the things we haven't talked about, and one way to potentially fill gaps, is our advanced practice nurses and our physician assistants. Heidi, I know this is something you've covered yourself. Now, 2013, our legislative session gave a lot more autonomy to these positions here. We have looked potentially in the last session, didn't work out, but it looks like in future sessions we're going to be looking at maybe giving more autonomy for these positions. I'm wondering, again, the resident's perspective here of getting care through a nurse, a high-level nurse, or physician's assistant over a doctor. What have you seen? What has been the response to that?
The response in Tonopah in particular, where we've spent the most time on the ground, has been very positive. In fact, Tonopah family medicine or Tonopah primary care practice is run by an APRN, an advanced practitioner registered nurse, who had been working at the hospital in Tonopah before it closed and identified that need for a general practitioner in town and went back to school at UNLV and got the degree that she needed to be able to go back to Tonopah and run that family practice and provide that primary care for the residents there. And I found her by talking to residents and patients in town who said, you know who you should really talk to is Marie Peterson. She's our family doctor. And they compared her to the sort of classic country doctor who does everything from helps your kid with his sore throat to helps expecting mothers with the kinds of vitamins and diet they should be taking. And then the other thing I wanted to mention on the telehealth front is that most of the patients that we spoke with in Tonopah really liked being able to see their primary care doctor via telehealth because they had the same person, and even though there was a distance, it didn't really matter to them. The technology at that point was good enough that they could feel comfortable building that relationship with her via telehealth. And then in addition to that, there was a physician assistant on site at the renowned health clinic in town who was there part-time in person for those patients who preferred that.
So John, it sounds like this is really a mix of services. We've got telehealth here, we've got our APNs and our PAs that are also providing service too. Yeah. Trust doesn't seem an issue. Is that kind of the main core strategy of what we're talking about here, is really a blend of different resources?
I think it's not only a key strategy. Nevada health centers, the rural health clinics that are typically based at hospitals, have now been doing that for a couple of decades. Team-based models that incorporate nurse practitioners and PAs has almost been a standard of care for the past 20 years. Another set of policies that I think are really critical and that I would consider to be quite an accomplishment coming out of the last legislative session was support for Nevada Health Service Corps. It's a program in which my office has written a federal grant which got funded at $500,000 contingent on the state coming up with another $500,000 in matching funds. There was bipartisan support for that legislation in 2019, and what that has resulted in is loan forgiveness to practitioners agreeing to practice in medically underserved areas. And right now we have 35 health professionals working in 15 counties, including Clark County and Washoe County, but more importantly, almost every rural and frontier county in the state. And where we see that as being really important is support for dental practitioners, but also support for marriage and family therapists, licensed clinical social workers, so that you're never going to get a psychiatrist to practice in a small community, but you can get mental and behavioral health services. And Nevada Health Service Corps is a key tool that we have in the tool chest to not only get them to come to rural, but to stay.
Well, let's talk more about the federal side then, since we're talking about kind of the mix in funding here. We have, obviously, our presidential seat is up. We have congressional seats that are up as well. These are very critical seats when we're talking about something like healthcare, rural healthcare specifically. And we've done a lot of talking, especially the campaigning so far, on Medicaid expansion, obviously Medicaid for all, but also whether we should continue, discontinue, expand, or reduce the Affordable Health Care Act as well. I'm wondering, just maybe we can go around the table. This is such a big issue on what potentially the expansion, the continuance of the Affordable Health Care Act, but then also what expansion of Medicaid in any way, shape, or form could do or could not do for our rural health care. Ali, I'll start with you.
Yes. So compared to people who live in urban areas, people in rural areas have fewer people have health insurance. So anything that we can do to make it easier for our communities, to pay people in our communities to get health insurance, to get affordable health insurance, that's something which I think will be beneficial to our rural health. So I've been working with my organization for now 8.5 years, and I've seen the change that the Medicaid expansion has brought, that so many patients who hadn't seen a healthcare professional in years or in decades were now able to get their healthcare needs met. So that has been very, very beneficial for the community.
Now, being that you're part of a federal qualified healthcare center here, and both on the Republican end and the Democratic end, we're talking about a lot of Medicaid and Medicare policy changes to how repayments are happening. Yeah. How could that potentially affect your center and the services that you're providing then?
Right. I think it's important that doctors' offices, including federally qualified health centers, get reimbursed for the care that they're providing. So we really have to get to a model that, we are providing care, quality care, and we get reimbursed for that.
Gotcha. Heidi, the uninsured rate has gone down significantly in our state, 44% to 14% since 2010 with the expansion of Medicaid and affordable health care. Again, out there, you're on the front lines. What are residents, saying?
The residents and, let's be frank, voters and taxpayers that we spoke to, the things that they're listening for and watching for don't only have to do with Medicare and Medicaid or insurance, although those are big issues. As John mentioned, it's an older, poorer population, so there's a larger number of people on Medicare and Medicaid, and they don't want to lose that. But they're also interested in other state and federal issues that people campaigning for office might want to tune into, such as transportation and telecom infrastructure. When you're talking about telehealth, an internet connection is critical, and we heard from many people that they needed better internet in their town in order to be able to access that care effectively. So I think they'll be listening for candidates talking about not just the ACA, Obamacare, insurance, but also some of those other things that are related to quality of life and the interconnected issues that line up with healthcare.
And John, let's talk about that. Let's talk about just the technology here. That's something the Trump administration has been campaigning on already, is an increase in broadband, an increase in the telehealth and being able to provide that infrastructure. Yeah. Does that really align with where we are going as a state or where our needs are? Slowly but surely, we are going in that direction. It's important to point out that a lot of the hospitals I work with were literally built shortly after the Second World War with Hilburton funds that saw a real huge increase in hospital construction and other health facility construction, including Nevada. That makes those really old facilities. Now, some communities have been able to do rebuilds or even new construction of hospital facilities, but the aging infrastructure of a lot of those facilities still needs to be addressed. Rural areas are the last places in Nevada to get broadband, so I do think that that's key. I would also add that we were speaking of insurance. I think it's important to note that in states like Nevada that took up the Medicaid expansion, those disparities in health outcomes between rural and urban areas is smaller than it is in southeastern states in the U.S. that did not take up the expansion. And so while there's still issues with Medicaid, particularly reimbursement of providers, it's made a huge difference in health outcomes in Nevada. I think that's a great way to end the show. We're out of time, unfortunately, but thank you so much. We really appreciate all of your time here. Now, if you would like to learn more about any of the topics that we've covered today, please check out our website at vegaspbs.org/Nevada-week. And also, you can always find us on social media at Nevada Week. Thank you again. We'll see you next time.